Hello and welcome to another segment with the Nairobi Hospital. Today we will be discussing about mental illness with the emphasis on depression. Now, depression, according to WHO, has affected about 300 million people globally. And it also affects the way we think, the way we feel, affecting our ability to work at home and other things that we do on our normal days. Today we are joined by Margret Sirima, who is the principal of the Nairobi Hospital at the College of Health Sciences. Karibu sana, Margret.
Thank you, Muthoni.
Maybe you could start us off by what mental illness is all about and how depression comes into that.
Thank you once again. Depression is a mental illness. And mental illness is a disorder or a condition that affects, like you rightfully said, the way people think, the way they feel, the way they behave, and ultimately the way they interact with the environment. That means people and what they do. And therefore, it's likely to cause what we refer to as social occupational dysfunctioning, affecting people's work, at home, at school, and at the place of employment. According to the American Psychiatric Association, there are more than 200 mental disorders. So depression is one of them, but it is a serious disorder and also common. Like you rightfully said, that about 300 million people live with depression globally. And in Kenya, about 1.9 million have depression. And that is those that have been diagnosed. We want to believe that there could be higher. It's only that diagnosis and therefore treatment is not as good as it should be because of some factors we shall be looking at. It is serious also because when it's not treated, it could also lead to suicide. And WHO also tells us that about 800,000 people commit suicide globally. So that's how serious it is. So just to define what depression is, it is an abnormality, it's a disorder that is characterized by abnormality of the mood. It is characterized by an abnormally low mood. To give the features of depression, which is important for us to know, there are 9 features of depression. But for us to say that you have depression, you have to at least have 5 features. So one needs to present with an unusually or an abnormally low mood, which is present and persistent nearly the whole day or the whole day. It could also be characterized by sadness. One is teary. And for the young people, it could be irritability and sometimes anger, which could even be misplaced. And then the other symptom is that one could lose interest in things that they used to enjoy. What we sometimes refer to as anhedonia. Maybe it's this young person who loved to play football, they loved to watch the TV, they loved to be on their phone, and no longer, all of a sudden, they lose interest in that particular area. Then those are the key symptoms. So somebody has to present with at least one of the two, together with the following: change in eating patterns. So they either are overeating or undereating. It could be change in sleeping patterns. They are not sleeping, or they have poor quality of sleep. They go to sleep, they are not able to sleep, or they keep waking up in the middle of the night. So basically poor quality of sleep. Or they could go to sleep and wake up later on in the night, 1 a.m. and are unable to fall back to sleep. Then there's excessive fatigue, loss of energy, then reduced concentration, hopelessness and worthlessness and uselessness or excessive guilt. It could also be characterized with, slowing down, just slowing down, what we refer to as locomotor retardation. Somebody is completely slowed down. If it's a mother, they're unable to cook for the family in good time. If it is a student, they can do their assignments in good time. If you're working within a team, you're behind the team and you may slow the team down. And then lastly, thoughts of death, ideas of suicide, sometimes plans of suicide, and sometimes people have even attempted suicide. And you may even live with people who have attempted suicide, but because it wasn't actualized, you'll never know that they had attempted suicide. I think not too long ago in the papers, there was this girl who wrote that she took an overdose of drugs, slept, and she was shocked when she woke up the following morning. So as long as somebody has 5 symptoms and they have been persistent for at least 2 weeks, then we should suspect depression. And why this is important for us to know, not everybody everywhere, from primary school, secondary school, at work, in the community, in the church, we need to have some of these, to know these symptoms, so that you can be able to identify deviation from normal behavior. In school, it is important that teachers know the children well, or the students well, peers know their friends well, because we spend so much time together, even at workplace. We spend a lot of time at workplace. So it may be easier for a colleague to pick up changed behavior, or that these symptoms have set in, as opposed to even a family member where you go home to sleep. As a country, we are more aware, we are better off than where we were. And maybe that is why the diagnosis of that prevalence that we are talking about of 1.9, that's why we are there, because more and more people are seeking for treatment. However, there's still a lot of stigma about depression, because if you are depressed, or if somebody says if you're depressed today, God forbid, the first thinking is, what is the husband doing? It is caused by others, and therefore, part of the reason why there's a lot of stigma. If a child is depressed, then people think, these parents are not doing good parenting, and this hinders people from seeking treatment. For a long time, if it happens within the church setup or religious forums, it is probably it's demons and things like that. So again, stigma, and I believe this is what these have been some of the hindrances to seeking treatment, or hindrances to talking about it. Yes.
You've mentioned about Kenya. And in Kenya, we have 1.9 million people affected. What groups of people are highly affected? We have the children, we have the men, and we have the women.
I think it cuts across. However, the prevalence is higher in women than it is in men. But it cuts across. Children as well, not just the youth, children as well that do experience depression. Again, it's important to know that people think it's maybe the day-to-day experiences, and therefore the thinking that a child then should not be depressed because they're not struggling. But risk factors for depression go beyond the daily events of life. We have biological factors, things like genetics. There's genetic predisposition, biological predisposition. Probably, the chemicals in the body, in the brain, they are reduced for a reason not of our own making. And therefore, you see, it could go beyond us. It goes beyond the family. It goes beyond the normal interactions. But of course, we have the life events, the experiences that we may have, which may become a trigger to an already predisposed person to depression. So it cuts across. I want to believe that probably women, the prevalence of women is higher, because we also have, that some hormones, that some female hormones, one called estradiol, has also been associated with depression. So therefore, probably that's why the prevalence is a bit high, just in my thinking. But also probably more women talk about it, and more women will go to seek help. We probably are talking with many men who are functioning on a day-to-day but could be depressed, and therefore their interactions, personal interactions are not as healthy. Yes, it cuts across.
Out of the 1.9 million people, are they all on treatment? They're all on treatment.
We know that in normal circumstances, not everybody who is depressed is on treatment. Many people do not go for treatment. And many people start treatment and they do not keep on to the treatment. So out of that 1.9 million, I can say probably with confidence that not all of them are on treatment.
And what could be the barriers to treatment?
There are several barriers. Okay. One, we have cultural barriers. The thinking that, you're a child, you should not be depressed, and you take your child to a physician, they diagnose depression, we need to put this child on treatment, and the thinking, no, children don't get depressed. So we have our own cultural barriers. We have barriers because of ignorance, like I said. We don't seek treatment for depression because we shouldn't be depressed in the first place. Or there are many other things we can do to stop this depression. We can alter the interactions at the home front, or we can actually withdraw that person from that environment that seems to be hostile. Then we also have lack of resources. We know that, for example, we only have not very many mental health hospitals, and even when they are there, there's already stigma in seeking treatment from those institutions because community has actually stigmatized that setup. And if you tell somebody today you cannot afford a private hospital, a private doctor, but there is a good institution where you can get help from, and it is a good institution where you can get help from, and people will be reluctant to do that because of what it's associated with. Then sometimes fear of being on treatment for the rest of your life. That's not usually the case. It's not always that you'll be on antidepressants for the rest of your life. You may start with a high dose, it's reduced because you're able to cope, and then when you have developed coping skills, when you're unable to in a healthy way interact with the environment, probably when the stressors that were triggering that depression have been reduced or have been removed, then one can get to a place where you can cope with psychotherapy and not necessarily treatment and medication. And let me say that not everybody who is depressed needs to go on the pill. We have many ways of there are several ways of treating depression, and one of them is counseling. Not every patient needs to go on the pill. They can, on assessment, one can be able to tell whether this is somebody who can be able to do well with therapy. Some people just need to be helped to handle or to develop coping skills, and when that is done, they are good to go. They can be able to interact with the environment in a healthy manner. They can be able to solve their problems and not get to the end of feeling overwhelmed. So then you have helped. There are those ones who may need to go on treatment, but probably not for long. And there are those ones who may need to go for treatment probably for a little longer.
The discussion on mental illness is approached differently in different countries. And I'll support my statement with this argument. In the first world countries, like let's say in America, United States of America, you can actually meet somebody and they'll openly tell you, I suffer from depression, schizophrenia, all those diseases, and they're open about it for how many years and the kind of medication that they're taking to manage their illnesses. How do we adopt such a system to reach a point where depression now in Kenya will not be viewed as a mwenda wazimu kind of case?
I think we need to get to a place where we can freely talk about it. In 2017, I think WHO, the focus was on depression. And there was, if I put it like the slogan, depression, let's talk. In other words, let's talk about it. And it is real, let's talk about it. So we need to destigmatize, to demystify this illness and normalize it. Normalize it, what do I mean normalizing it? We can comfortably say that I have hypertension and I'm on medication. So we have to destigmatize it at every level. Good understanding of what it is, that it is a disorder, like any other disease that can be treated. And I think probably part of the why there is stigma is that most people who are mentally sick have been found on the street where there is poor no management. We don't need to get there. So and maybe the thinking as if we get there, if I have this, would people, if I say I have depression, would people be thinking that this is the next place that I'm going to? You see, one of the places, one thing that happens is that when somebody is in trouble, they run to a safe place. And one of the safe places to run to is to the church. So then even at that place, people need to know this is an illness like malaria. And so with treatment, this person can recover. Only then, if we are talking about it comfortably at an institutional levels, social organizations and so on, then people will be better able, or they will be more comfortable talking about it. Then even at corporates and with employers, because some people, when they have a mental illness and depression, probably it reduces their opportunities for growth.
Yeah.
They miss out on opportunities. And yet we know that if they're well supported, they can function just like anybody else, or probably even better. And so if we know, if we get away from that place of destigmatizing at the family level, at the community level, institutional level, then we'll be better able to talk about it. And also, anybody who has gone through it, in this country, I am not very sure that we have people who are in top corporates or probably significant members of the society who can come about and say, I have depression, I have coped, look how far I have gone, I am very productive, but I am in control, I'm in charge of my life. Only then will people say, you know what, people are talking about it, so let's talk. Yes.
Do you have enough resources and also healthcare providers in dealing with mental illnesses in Kenya?
We have very few psychiatrists. If I'm not wrong, I think the current statistics I saw was 88 psychiatrists in the country. There may be more now. And then about 450 to 500 mental health trained nurses. But let me also say, apart from those that have specialized in that area, any doctor who goes through medical school and any nurse who goes through a nursing school, they go through training in mental health. And there are also rotations in those clinical placements. So any healthcare provider at the level of the nurse and the doctor, and I believe the clinical officers, know and would understand these disorders. And for that reason, I would say we may not have too many, but at least we have enough who can be able to diagnose or to suspect and therefore refer for further treatment. Yes.
So in our discussion today, depression is treatable. Any mental illness is treatable. Mental illnesses
are treatable. We do appreciate that there is some level to which one may not go back to normal functioning, but yes, it's treatable. We have some mental disorders where once diagnosed and it can be controlled. Somebody may not go back to their previous level of functioning, but they can function to a level and they can be supported to function at that level. I think before we finish, let me say this, that often when people do not understand their symptoms, they do not understand why they are the way they are, they may, and they have these negative feelings or negative emotions, they sometimes go to self-treatment. This could even be using substances of abuse, substances, for example, alcohol and other prescription or non-prescription drugs. And so if these substances make them feel better, it numbs their negative feelings, and it makes them feel normal, they can sustain this, and it may now lead to another problem, that is substance use disorder. And when it gets there, you actually increase the risks for suicide, because depression in itself is a risk for suicide when it's not treated. When there's a combination of substance use, it even becomes worse. So, and that's why it's important to be able to diagnose early, seek for treatment, so that one does not need to go that path. And probably, because we know that there has been a very high prevalence of use of alcohol and other substances, I think at some times it even, even the head of the state addressed that. Could it be that people are going through this path because they have, emotions that they are not able to understand and therefore treating them? Something good to explore. Yeah. Thank you.
Thank you very much. Thank you very much, Margret, for that insightful information on depression. And I know people will be open to talk and reach out to people who have also been affected and advise them to seek treatment. Thank you very much for joining us today.
Thank you very much for having me.
Let's continue with this wonderful conversation in the comment section below, and both our websites, that is the Capital FM website and the Nairobi Hospital website. I've been your host, Modoni Wabero.